all to today's continuing medical education session conducted by the Department of Dermatology of Government Medical College, Ernakulam and the Medical Education Unit on HIV/AIDS on the occasion of World AIDS Day observed on December 1st. We are gathered here today with a shared commitment to learning, advancing our knowledge and enhancing the standards of healthcare in our community. Before we proceed with today's program, let us take a moment to pause and reflect in silence. I kindly request everyone to rise and join for a moment of silent reflection. Thank you.
This year, 2024, the World AIDS Day theme is Take the Right Path. This theme emphasizes the importance of upholding human rights to combat the HIV/AIDS epidemic effectively. It advocates for the removal of legal and social barriers that infringe on people's rights. The theme also encourages leaders in communities to promote inclusive policies and create legal frameworks that support HIV prevention, treatment, and care without stigma. This CME session has been thoughtfully organized to include a series of expert presentations, case discussions, and interactive sessions aimed at fostering collaboration and knowledge sharing. We are fortunate to have our esteemed guests with us today to guide us through these thought-provoking discussions.
With that, it is my great pleasure to formally kick off the CME session. To begin, let's start with our first session. I would like to invite Dr. Santosh George to chair this session. Sir did his graduation from Academy of Medical Sciences, Pariyaram, presently Government Medical College, Kannur, and his post-graduation from Government Medical College, Trivandrum. He has then taken MPhil in Clinical Epidemiology from School of Health Planning, Trivandrum under Kohas. He is currently the Associate Professor and Head in charge of the Department of Oncology.
So good morning all. The last week one of my friends gave me a call and asked me to inquire about a patient admitted in neurosurgery department at Port. So I called one of my closest friends there. And he told me that the patient will survive anyway, he may go into a vegetative state. And he revealed to me that he is HIV positive also. And to my stupidity, I told this to my friend. And the initial reaction from him was, so he still is with the HIV status. And after hanging up the call, I understood that I did something very stupid. I have violated the law. I called him again and explained to him about the professional secrecy that he should not tell anyone. And a more important question is, can the neurosurgeon reveal this to me? I am not a treating doctor. I am not going to taking care of the patient. We know that it's because I am his friend he revealed to me, but legally can he reveal it to me? And the more important issue is the penalties that are prescribed in the Act for all these violations are very strict ones. They have put "and". Whenever we see "and" in an IPC or BNS, the issue is we will go behind the bars. എവിടെയെങ്കിലും നമ്മൾ "and" കണ്ടാൽ ഇപ്പോൾ ഓറാണെങ്കിലുള്ള ഗുണം എന്താ വെച്ച് കഴിഞ്ഞാൽ we can keep fine and escape. They have put and pretty good imprisonment is also there. So these are very serious issues. And there are very interesting questions also. If one of us turn HIV positive, can we continue as a surgeon or a physician? Or are we entitled to have a reasonable accommodation? All these questions are very relevant. And the Act answers all these things. So unless other acts, this is a pretty interesting Act to listen to. So please madam, we will proceed with the topic.
Now let's invite Dr. Parvati, who will speak about HIV/AIDS Act. She has retired from the Health Service Department as District RCH Officer and joined as Medical Officer of the ERT Center in General Hospital, Ernakulam in February 2016 and continued. She has also received the Best Doctor Award in the Health Service in 2010. She has been in association with KSAX and the PLHIV since the year 2003. And she is also a trainer for HIV or AIDS since then.
Thank you all. Let me first of all thank the organizers for having invited me here today and to talk to you a few points about the HIV/AIDS Prevention and Control Act. As we all know that maybe so many of us would have come across many of the HIV positive patients, and I do not know whether everyone had the same thoughts about them, whether their behavior to them were all the same. I'm not very sure about that. But I will restrict my talk to the Act and whichever is important for us. Not everything we can cover in a short period of 30 minutes, but we will just go through wherever we have to be careful about. Because as Sir rightly said, this Act is very strict, and if they go in upholding the Act, anything can happen to any of the person, not only medical personals, but the others also, their family members, their neighbors, their relatives, friends, anybody can be held to the court. So it is very strict. Maybe it was passed in 2017, but it came into force in 2018. One of the reason may be that they're afraid, they have a self-stigma to reveal that they are positive. So maybe that is why they are not going after the Act, not they are trying for any legal action against anybody. Because many have told me like, if I go into the court, everybody will know that I am HIV positive, so that will be more worse than this. So, but I will keep quiet and suffer to myself. So they come and tell us all the complaints regarding how they have been treated at home, how they have been put out of their families, and how they have been not allowed to enter a school. Then when I ask them to go in and I tell them, why can't you go to the lawyer? But then they are like, they go back. They want me to correct everything. I can't do anything about this. Even one lady is there, she is paralyzed, and her daughter is a staff nurse in another country. So this lady's daughter-in-law, she is acting very strangely to her, talking ill about her. If suppose any homeless comes to look after this, homeless hey, Asri HIV positive, she's like driving out all her assistants. So but this girl staying so far, she is not able to help her mother, and she's keeping on calling me. How can I help them? I cannot take any legal action. So I tell them, you meet the police, meet the advocate, I'll give you the phone number. But they are little hesitant to do that. So I always tell the PLHIV also, you should come out of that aura of that self-stigma. If they come out of the self-stigma, maybe they will try for all this to put into force. Similarly, we also think about how the age population has changed from the older generation to the many younger population, people in the younger generation. They are coming as positive. So I feel that it is a good sign that many of them are out of this self-stigma. They are coming forward to get tested. So I always tell, we cannot generalize that all the young adolescents and adults are more numbered in HIV positive. We cannot generalize like that, because maybe they are getting tested more and the elderly population are not getting tested. So in that way, I think the Act also they will start using that. Then as Sir said, we will have to be very careful. So I will not waste any more time. So there are so many, what is the use of this Act? As he said, it is mainly to prevent and control the spread of HIV and AIDS. Why I said about to prevent and control? Suppose there is no Act, they will not get tested even. So as everybody always says, our 95, at least 95% of the people should get tested. So if there is an Act which prevents their confidentiality, which will not do any harm to them, only then people will come forward and get tested and start taking treatment, and only then if they become virally suppressed, this disease can be limited or eliminated. So indirectly this also helps to prevent and control the spread of HIV/AIDS in the community. Also, as said about our rights, everybody has human rights and also legal rights, and it also helps them to reinforce their rights by using this Act. And also there should be a grievance redressal system mechanism where they should go when they have some problem and that will help them to fight against their problems which are raised against them. So this is just about the genesis of the act. It is nothing more important. Only thing is, though the act was passed in March 2017, the HIV bill was passed by the Rajya Sabha on 21st March of 2017. The central government rules have been notified on 17th of September 2018. So it is valid from 2018. It has come to force. So where this is applicable, which part of the country or which part of the state, as it will say that it is applicable in the whole of India, and this act of 2017 is applicable whole of India. Then there are several definitions. I think all these everybody would be knowing. I will not go into details what is meant by. I want to remind you one thing. When you say that a person is HIV positive, never brand him as an AIDS patient. That is strictly against this act, because AIDS is different and HIV is different. HIV positive doesn't mean that he is an AIDS patient. So we will not go and ask, you should never say. We can be taken to the court. That terminology is wrong. So as we all know, two definitions are different, and it also says about what is an HIV test, who is an HIV positive person. HIV positive, you definitely know. Whoever it is tested as antibody positive is a HIV positive person. But it can also be HIV affected persons. That is, suppose a wife or a husband is negative and the children are negative. They are all HIV affected persons. They come into the group of affected people because they are being affected by this, but they are not infected. So that infected and affected are two different terms. And protected person, who are all coming under the protection of this act. Discrimination, we all know, is simple English. And informed consent would mean that before for every action in association with these patients, before they are getting tested, before they are given treatment, everything we need informed consent. So before we test a patient, we have to get their informed consent. Before we start them on antiretroviral treatment also, we have a consent form, and the new white card has a printed form inside itself. So we have to get an informed consent. Then it describes what is an establishment, that we know, who is a healthcare provider, we know, significant risk, who are the risk population, we know, and also defines what is state AIDS control society. And the most important part of this act is regarding discrimination. That is section 3 of the act, which is the most important section of this act. It says that they should never be discriminated, they should never be denied of anything, whether it be education, residence, property accumulation, or job opportunities, healthcare facility. They should not be denied any of these things, and they should not be terminated just because they are an HIV patient. They should not be terminated or not given a job. So we will quickly go through. That is their right to. There should be no discrimination against employment or occupation. When I think about this, one of our patients, he is a pharmacist. Yeah, the other person was a radiographer, and both of them were not taken into the job itself. Not that they were sent out of the job after they were known, but while they were going the process of selection itself, these people found that they are HIV positive. So then they came and asked me, I am HIV positive, will I be denied of the job? So I said, there is no way they can deny a job just because you are HIV positive. But unfortunately, there is a law for everything. Every law or every act has a law. So this hospital will never say that, will anyone say that because you are HIV positive, I am not appointing you. They never said that. Only if they say that, they will be held to court. So they said that, we have got better personnel, we are very sorry. Till the last evening he was selected. The next morning they say that, no, we are sorry that we are not able to appoint you. So that is how people are getting away with this. As I said, there's a loophole for everything. They should never be denied of any employment. In our hospital also, there are many HIV positive patients who come in maybe for contract appointments, not a regular appointment. So in the beginning, my superintendent used to ask me, that person is HIV positive, is there any problem if I select them? I said, there is no problem, sir, you can go ahead. There are so many HIV positive patients being employed in our hospital, because our superintendent has taken it in the right sense. He has understood everything. He understood that they should never be denied of any opportunity. So that should be the fact that in every employment or occupation. Then coming to health care services, that all of us know that they should not be denied of health care facility. Unfortunately, still there are hospitals who deny their treatment just because they are HIV positive. But some straight away say that we have no facility to attend your delivery because you are HIV positive. We have no facility to do this surgery for HIV positive patient. They stay straight on their face, not knowing the implications of the act. And some very slyly they will get away with the patient not catering or not giving the treatment. So that is again a problem. That is also a discrimination. Coming to public places. Few years back, when I invited some of my PLHIV friends, I invited them to come for my daughter's wedding. So for my son's wedding, actually, it was just a small gathering, a reception. It was not intentionally. I just called a few people, and these people were left out. And they came and told me, "We know, madam, why you didn't invite us." I said, "What do you mean?" I didn't invite all my friends. I didn't invite all my relatives. It was just a small gathering. I never even thought, the wildest of my dreams, I should discriminate you. So the next time I was very conscious. I should not leave any of them, and they should not have any problem. And they very happily came on the stage, took photographs with me. And public places, we should not deny them to attend any public places. Educational establishment, we still have a child who has been put out of the school. It was a residential school. Unfortunately, he has lost his father. Only his mother and the child is staying. And she is also a type of a weird character. She still goes on with her risk activities, so she can keep her son with her. And the son is quite an adolescent. And once the school came to know that the child is HIV positive, they very coolly sent him away from the school. We cannot go up, I cannot file a case against the school. And they are not in a position to file a case and go after the case and get an admission. That's all a laborious process. And now we are in search of putting this child to another school or a hostel like where he can study. Then coming to right to movement, they can move anywhere across the country, anywhere in this country. There is nobody can deny that, say you cannot get into this bus. So previously before coming to this ART center, I used to go to their gatherings and talk to them about treatment, about positive living. So many of them know me even before I came into this post. So when I used to go travel by bus, they used to come and sit near me. And once one lady told me, "I can sit without any hesitation near you, madam. That's why I didn't sit there and I came and sat near you. Because I know that you know me and you will not discriminate me." So that is why I thought, who is going to know wherever you sit? But still that self-stigma is in their mind, I should say that. So we should not discriminate them in movement or travel. And right to property. And they can hold any property, any amount they can, as much as they can. And also opportunity to hold any office. He may be a medical superintendent, just because he is positive, he cannot be sent out of the hospital or any higher post also. So these are some of the important aspects on discrimination. And certain acts are there. Section 4 of the HIV/AIDS Act, it prohibits certain acts which some might do, that is like a hateful speech or any using physical violence against them, either by writing or talking or speech through their spoken words, or publish their anything against them, or communicate even by sign language. We should not communicate even saying that they are such a person is positive, and they should not be disseminated or broadcasting or advertisement or any type of information should not be propagated. And next, coming to another section is 5, 6 and 7, which says about informed consent. We earlier said we have to seek and get an informed consent of the person, or suppose he is unconscious, through his representative also we can get an informed consent. Priorities for conducting an HIV test. Previously, the older generation population used to come and tell me that we didn't know that we are HIV positive. Nobody talked to me about HIV or my risk behavior. They just tested me. Just because I went in for a surgery, or without counseling, we are not supposed to do any testing. as a routine testing, we are not supposed to do a HIV testing. We have to do pre-test counseling. We have to get an informed consent from them. After that, you can do the test. So there are some who denied getting tested, especially when it comes to post-exposure prophylaxis. Some of the nursing staff used to come after getting a needle prick. So I used to tell them, you go and get tested at the ICTC. After that, we will deal with the matter. One girl, she strongly resented. She said, I will not get tested against HIV. So I still wonder why she denied getting tested. Because she is just a student and she will go after 1 month. We cannot trace her also. So she said, no, I will not get tested. So we cannot test her. We do not know whether she was already positive or she had a risk of getting the HIV. But she denied, she didn't want to get tested. So that is, at that time this act was not there, but still we had no other way to get her tested. And then conducting medical treatment or intervention. So even before we start the treatment, we get a consent from them. We will explain to them about the ART drugs and what are the minor side effects which can happen, everything about that. And then after getting a consent, we will start the treatment. About medical intervention and research also, the Act also says that very often, sometimes we get requests from various organizations to get doing research on them. But we are not supposed to do that. But even if the AIDS Control Society asks us to do a research or do some topic discussion on something, we give a consent form to them and ask them, this is what is happening, and this can be used for a paper presentation. When they hear that, they will say, no, we are not willing. If it is going in for a paper presentation, I will not allow. So that consent is very important. We cannot do something slyly because they are our patients. We cannot do a research on them without their consent. So the informed consent initially for testing, I said it is pre-test and post-test counseling. And when the woman is pregnant, sometimes the husband might come or her relatives might come and say that, okay, we do not want to continue with this. We want the pregnancy to be terminated. Or or in some cases we will say that, they might say that we want her to get sterilized. But we cannot do that without her consent, without the consent of that woman, without her informed consent about sterilization or abortion or whatever it be. But there are exceptions to this informed consent. That also is there. In section 5, 6 and 7, if there is an order of the court has ordered us, the magistrate or has sent a letter asking for, there we need not insist on the informed consent. That is an order of the court. We will not be held to court because we are doing it. And for using medical research or therapy, that is as per the, if everything is in place, after we meet, we have a committee, after they pass, we can do that. And especially in screening purpose, in licensed blood bank, whichever blood bank is coming under AIDS Control Society, and they have a license. For screening purpose, anyone who goes in for donation, blood donation, they will get tested. But maybe at that time of screening, they will say that we are going to do a battery of tests for you before you take the blood. And in that cases, for screening purpose, just for screening purpose, they need not take the whole blood. Just for screening purpose, they can use without any consent. But after that, they are supposed to give them counseling and tell them there is some problem, you can go to the ICTC and get the remaining tests done. And for surveillance purpose or for epidemiological purpose, that will not be, we need not insist on an informed consent. So these are all aspects of exceptions. Then disclosure of HIV status. That is coming under section 8 of the HIV and AIDS Act. That every person who is HIV positive, he has a right to not disclose his status. We cannot compel him that you have to disclose your status. We cannot insist that he should disclose his status. Suppose they feel that I do not want to disclose my status, we cannot do anything about that. So he cannot be compelled except by the court of order, order of the court. But suppose the court says that we will have to disclose the status. So that is very important regarding, and there are exceptions to seeking informed consent. We already said a few things. One is disclosure between healthcare providers. Suppose we have to disclose his status so that it will be of advantage to the patient. Because only if I disclose his status, it can be advantage to the patient. So I always tell, we always tell our patients, when you go in for a consultation, just reveal your status. Otherwise, the doctor will not know. Suppose a person is going to an ophthalmologist. He is just simply saying that I have slightly diminished vision. The doctor will not go into a battery of testing. He will not look specifically for a CME retinitis. Only if you tell the doctor, he might look specifically for that and he can get a treatment for that. So we always tell them to disclose the healthcare provider. And between healthcare providers, suppose I want to refer somebody to a doctor, I should tell him no previously. So there you can, we need not get a consent from the patient. Order of court we said, legal proceedings we said. Then coming to disclosure to partner, we will get into detail about that. And for some other statistics, for taking statistics and surveillance, that also we had told earlier. And coming to disclosure of HIV positive status to the partner, that comes under section 9. Who can disclose the status to a partner? That is very important. Only a healthcare provider, a physician or a counselor. Not everybody, not a person. Suppose a person is admitted in the ward. The staff nurse or the clinic staff, they cannot come and call their relatives or their partner even. Tell, see, your husband is positive. It cannot be done. Only a doctor or a counselor may disclose the status to the person who is under direct care to his or her partner. A few days back, I got it was a fraud call, and that person was asking me about a patient of mine. That was not anything related to this HIV or anything. That was some money fraud business. So a phone call came. It was just a mobile number, so I picked up the call. He asked me about the details of one of my patients. So I said, why do you want to know all this? I do not know anything about him, I said. So the next thing he was telling that this person has taken a loan, or it was all a false call only. But still he was telling me, why you are saying that you don't know about the patient, you are his doctor. I said, sorry, please put the phone down. I do not know anything about this patient and I am unable to speak anything. So we need not answer such calls. We need not disclose such things. So the healthcare provider believes, suppose we can reveal the status to his partner. There are still some patients. Maybe here also there may be few patients who have not revealed their status to their partner. We still have, our ART center was started in 2009. And till now there are patients who have not revealed their status to the partner. So the partner, suppose we feel that, the doctor or the counselor feels that if the status is not revealed by this patient, his partner is at risk of getting the disease. So in that case, we can reveal to the, because the partner might say that we might feel that this patient is not using any protective measures and the partner is already negative, he might transmit the disease. So in that case, suppose he is not revealed the status, we can tell them. And suppose the HIV person, and in this case, if the HIV positive person has been counseled to inform such partner, and we are sure that he says that I am unable to inform my partner, but we have counseled him, told him everything, and in that case we can reveal the status. And the disclosure should be done in person after counseling. There also we cannot just call him or her and tell them that your partner is positive. After counseling, we can tell them. There are many, I hope all of you know that HIV positive people they can marry anybody, positive or a negative person. So suppose they tell me that I am planning to marry a negative person, I am in love with that girl or boy, I tell them please bring them here. I will do a counseling and reveal your status. And after that still they are willing to get married, you can go ahead. There are many who have got married, many who had children, none of them got positive because they are all virally suppressed, and that can happen. So I will counsel everything and then they can go in. So disclosure should be made in person after counseling. And another important thing as per this act is the healthcare provider, he cannot be legally liable for any disclosure or non-disclosure. Previously patients, some people used to ask me, why didn't you reveal the status to me before he died? If you had revealed the status to me, I would have taken care of him. But we are not supposed to disclose like that. The patient kept on, we had a young man who was very healthy. He was nearing 30 years. He was there ever since I came also he was here. but his relative was a doctor in our hospital. We were unable to even to disclose it to that doctor. He was a high profile patient, but he never was willing to start the treatment, ART. And finally his CD4 came down very low, his weight he lost weight about 35 kgs, and at that time he is telling, I will take the treatment. So of course we started the treatment, but everything was beyond our control. He developed PCP pneumonia, he had miliary tuberculosis, he had severe candidiasis, and finally we lost him. The last stage only he said, okay, now you tell my mother. So only after he said we could open our mouth, because he was an educated person. We were not supposed to reveal his status, and that time his sister was calling me and telling me, doctor, you could have told me before, I would have saved my brother. I said, I am very, very sorry. More than this, I cannot counsel him. He never wanted to be the status to be revealed. So then we cannot be held liable by the court for any disclosure or for non-disclosure. It is beyond our things. Then we said about disclosure of HIV positive status. If for a woman, suppose a woman is positive and husband is negative. So the positive partner, if the woman is a positive patient, there is a reasonable apprehension that if her status is being relieved, she can be subjected to mental and physical violence, because maybe they will take it in a wrong sense. They might say that she is a sex worker, she has contracted the disease. Even if when both are positive, suppose the husband dies first, unfortunately, and we are seeing the patient may be with us only for a few days, and after that some come in the terminally ill state, and the husband passes away and the woman is left alone. Even in that cases, the woman is at fault always. They are putting the blame on the woman. My son was perfectly okay, it was only because of this woman. And more so if the husband is positive and the woman is negative, and that will add on to their problem. So in that cases, it may have a severe negative effect, and we have to be very cautiously to disclosure of her status. Then the Act section 10 also says about what are the risk reduction strategies. It does not just say about the rights of the PLHIV. It also says about what are the things to be done for transmission prevention. That HIV, a person with who is HIV positive, he has to inform the HIV status before having a sexual contact. Will anybody reveal his status when he is having a sexual contact? Nobody is going to reveal his status. So we can we cannot tell them that for every sexual act, maybe he is a male homosexual or a female sex worker, they may be having more than 2 or 3 partners every day. We cannot tell them you go and reveal your status and have sex. They will never do that, though they access that. But we can tell them at least to use a condom. That we can insist them. That is our right to tell them. That is our responsibility to tell them. And when they share, we can only tell them that you please do not share the needles. That we can tell them. That is also part of this act. Then coming to establishments, that act is section is 17, and we have to keep all the records regarding these patients very carefully, confidentially. Data protection is very, very important. No data should go out from our institution or our office establishment or wherever this patient is or the person is working. The data should not be let out from that will be very serious offense. And procedure for accessing information, that is also very important. We have to keep everything protected, secure, and accountability, everything comes under this act. But unfortunately, in an establishment where a woman was PLHIV was working in almost a top post, unfortunately her status got revealed even to her not only to the office staff. The office staff, they were knowing that she was positive, but it leaked out from her office to her higher office, and she had so many problems, and that case is still going on in the court. She was strong enough to go to the court. So that is what is happening. That will happen if it goes out from our. And the act also says about what are the welfare measures that should be adopted by the central government and the state government for this PLHIV. For the all the diagnostic facilities, antiretroviral treatment, opportunistic disease management, that the responsibility lies in both the governments, and they should have a better access to all welfare schemes. There are many welfare schemes provided by our Kerala state government that many of us know that they are being provided with 1,000 rupees per month as a travelling allowance. I keep on reminding them it is for traveling, not to go to the, not to have a drink or not to have food or have a party, or it is not given for all those things. It is for you to travel from your place of stay to the place of treatment. It is with that intention they are giving 1,000 rupees, but we do not know what they are using it for. And finally, when they miss the tablet, they come and say that I didn't have money to travel, it seems. Then I really get angry. I tell them, you can utilize this money for travel, not for drinking alcohol or anything like that. So they have many welfare schemes, and they are being provided with nutritional kits through the social service department, social welfare department. They are being provided nutritional kits every month through the Jilla Panchayat or through the corporation. They are being provided that. And for students, they are giving all, they have many methods of providing. There are schemes for scholarships for the students who are joining the government institutions, not in the private facility, for the government institution. Then those who do not have a home, if they have so many land, they have landed property, through the Life Mission they are being provided free houses are built free of cost. So all that schemes they can, as mentioned in the theme, they have to use the rights correctly, not through the wrong pathway. They can use, they should utilize their right through the right path they should take. So that is what is meant in the theme also. And the government should adopt all IEC programs. Even few days back when I met some officials in connection with this program, they are asking me, is there HIV positive patients till now? So I said, yes, sure sir, there are many patients coming every day to our ART centers. I said, I don't see any messages anywhere. It's not a layman who is speaking, it's a higher official. I don't see any advertisement or any messages. Previously they used to post so many things on the buses and the train, everywhere it used to come. And messages used to be passed on through various media. But now I don't see any messages. So I think our government should be slightly addressing more to that. We always keep on asking our department, please give us more IEC materials. So the problem is from the state, central government. They have sent enough material, IEC material, but everything is in Hindi. And our patients, not all are migrants. We have many our Malayali patients. And even I can't understand most of the words. So how do we present that? So IEC programs, but we make our doctors themselves speak on various aspects and play it in for our patients we play. We cannot play it in, we have no mechanism to play it in a public place. So that is what is said, that welfare measures. And counsel and provide information regarding the outcome of pregnancy and HIV related treatment. So we tell every patient who comes to us, you can have a family, you can live up to 120 years. Do you believe they can live up to 120 years or not? What do you believe? Can they live? Definitely they can live. I had a patient who was just 60 years. So he is a patient, he has a COPD. One day he comes and asks me, how long will I live, doctor? He has been on treatment for maybe I think 20-25 years. How long will I live? So I saw his age is 60 years. So I said, 30 years more you will live. I thought 90 years is perfectly okay. I do not wish to live till 90 years. So I thought, hearing his question, I felt he wants to live long. So in spite of his constraints, he wants to live long. So I told him, you will live for another 30 years, don't worry. So he was putting his head down and very sad. I said, why? You want to live still longer? Yes, madam. I thought I can reach up to a century. At least 100 years I could live. So I said, is it so? And you will live up to 120 years. Don't worry, I said. You should have seen the glow on his face. He was so very happy hearing that. I said, I will not live till 120 years, that is for sure. I do not want to live also. Then I said, anyway, you will live till 120 years. And you are only few years difference between you and me. So I will be either in the hell or heaven, wherever I am placed. I will see from there what you are doing at 120 years. You should also remember that when you reach 120, you should remember about me, that I am not here, but the doctor is not here, but you are here. So he was smiling, so happily he is going on. So people are like that, they should be motivated. They would like to live, I suppose, I don't know. And pregnant women also, I tell them you can have a baby. Some may be serodiscordant couple. In some cases, the husband is positive, wife is negative, or wife is positive, husband is negative. Then we call them as serodiscordant couple. So they may be already having one child, but they will say that because of family pressure, our society is like that. No, everybody should get married. Anyone who doesn't get married is something, some strange character. And once you get married, you should have children. Not one, but at least two you should have. All that is set pattern in the society. So I cannot blame them also. They come and tell me what to do, madam. My family wants me to have another child. I said, wait for some time. You have just started the treatment. Let you become virally suppressed. Let your CD4 count be at least nearing 500. And let your viral load be less than, let you reach the status as target not detected. Then you can have a child. So like that we promote them to have a child. Whenever they are virally suppressed, we are sure that they will not transmit the disease to the other partner. They will not transmit the disease to the child. So that is how things are going on. That is also a part of the act. Then coming to protection of property of children. Maybe they have lost their parents, or the parents are very ill. They may be planning to give something to their child. So property of the children, there are also measures to protect their property. They can contact the child welfare committee, because they will keep it safely, all the matters related to their property. So that is regarding protection of property of the child. The responsibility of the establishments I already mentioned. Another thing mentioned here is about universal precaution and post-exposure prophylaxis. We have to ensure that we have to inform and train all our healthcare providers regarding universal precaution and the post-exposure prophylaxis. That I think you would have, I think there is a session by Dr. Anto, he will be telling you about that. And that is also coming under that also we have to ensure. And there should be a grievance redressal mechanism. We can either keep a box, or you can have a complaint officer where these people can approach, wherever who is positive can approach. In our complaint box, or in our grievance redressal box, they put not any complaint, but they will write all weird things, and they will ask for their needs, they will write in the box. That happens everywhere, I think so. Not only in our ART center, and all the establishment, that is what they are using. Then strategies to reduce risk. I said about IEC activities. Then about provision of condoms for safer sex. So any strategy or mechanism that we adopt, nobody can hold us liable legally because you are providing condoms. You have kept the condoms in an open space. Nobody can say like that. That is all for a risk reduction mechanism. Information materials we can exhibit, and provide safe injection practices. All that comes under this act. Then also it is about employing an ombudsman. So the duties of an ombudsman is being appointed by the government, and the role of the ombudsman is to put into practice section 3, as we said earlier, about discrimination. That is a very important section. Everything relating to violations, act of discrimination. And he should resolve the complaint within 30 days of receipt of the complaint. And in case of any medical emergency, he should provide it at the earliest, at least within 24 hours of the receipt. That is how these are some of the duties of the ombudsman. And then coming to right to residence, that is section 29 of the act. And the positive persons, they can reside in a shared household. They need not stay alone. They can stay with their parents, their partners, their relatives. They can share a household in a non-discriminatory way. There are PLHAV who are staying in a shared household, but not in the way that the act says. They have been discriminated. They have been kept separate room, separate things, separate plate, separate food, separate toilet. Everything they are being provided separate. That is not the way they should be treated. They should be treated as one of their own and in a non-discriminatory way. They are not supposed to have food along with the other members. They have to have the food before or after the member, maybe probably after the members take only. They will not ask them to take it before. So such discrimination are still there. And guardianship of the older sibling. Maybe and the sibling is below 18 years, but not below 12 years. and they have enough maturity, they have lost their parents. We had a few children who had lost their parents earlier, and this was their elder sibling was taking care of the younger sibling, because he was less than 18 years, but more than 12 years, but he could manage the family matters, and below the age of 18 at least for admission to schools or care and protection, taking them to treatment, managing their accounts. If they are, probably they are able to do that. So that is also under that. Then identity protection, legal proceedings. We said that the court can ask for their identity, we will provide them. But the court can suppress the identity of an HIV affected person who is a party in a legal proceeding by, they might change their name, or they may do in-camera proceeding and restraining the publication of these details. That the court can do. Then penalties. Then coming to penalties. So we have detail about the various sections of the Act. Penalties is very important. So violation, if it is fine or if it is imprisonment. The most important section is section 3 and 4. And 4 is propagating hateful speech or words or writing or actions or anything would be propagating hate, discrimination or physical violence. That comes under section 4, and the fine there is it may extend up to 1 lakh rupees, and imprisonment not less than 3 months. It may extend even to 2 years. Sometimes both fine and imprisonment both can be awarded to this person who has done this penalty, who has done this mistake. And second is section 26, which says about the failure to comply with the orders of the ombudsman. This person would have complained to the ombudsman would have ordered them to do such and such things. If you are not complying to their orders, the fine may extend up to 10,000 rupees, and additional fine of rupees 5,000 every day the failure continues. So strict is that law. And coming to section 34, that is breach of confidentiality in legal proceedings. If they have told that you should not reveal my name or you should not reveal my details, and legally they are not complying to that, in legal proceedings also if they are not if they are breach of confidentiality, it might extend to rupees 1 lakh. So these are the penalty for this violation of the Act. Then we cannot victimize them. No person can be victimized just because they made a complaint under this Act. Suppose a patient is, we have a patient and the patient is filing a complaint against me or anybody else using this anything in this Act. I cannot victimize him. I cannot keep on troubling him just because he had made a complaint against me. So that is important. If he has appeared as a witness in a proceeding. All these are some of the important facts under victimization. Then coming to this, this is nothing very serious. What is the role of the SACS, State AIDS Control Society? They have to formulate the state rules. They are the persons who will formulate the state rules, state IEC activities, and the setting up of complaints officer, about posting of ombudsman, and all that is coming under their role. So coming to the final slide, that is about the key points regarding this. I have been telling about so many sections and all the sections, even I can't remember the name of the number of the sections, only the important ones even I can remember. So the key points of this Act is just this. Discrimination against persons living with HIV for the purpose of employment is prohibited. As far as we are concerned, we cannot tell, no, we will not employ you. And conducting an HIV test, medical treatment or research on a person without his informed consent, that is unlawful. So before everything we should have a pre-test counselling and a post-test counselling, and then only we will go in for that. Then another important point in this Act is no informed consent is required where HIV test is conducted anonymously and not specifically for the purpose of identifying this individual. Maybe we are just doing a surveillance just to know how many people are positive in this community or in this epidemiological study. And forcing a person to disclose their status unless by a court of order. We cannot, it is all prohibited under this Act. Then antiretroviral treatment is a right of all HIV infected persons. We cannot deny to any HIV infected person, wherever he is staying, whether he is staying in this district or from other district, for other state, even from persons from, we give medicine even to people who are coming from abroad. We cannot deny that because he is not an Indian national. We never deny them. As long as he is with us, we are supposed to provide them antiretroviral treatment. Then grievance redressal mechanism at an institute or hospital should be there for them. We can keep a box or complaint box where they can put in their letters, and we have to open it once in a week or once in a month. We cannot remain it like that without opening. So after that, then we have to find out a solution. We have to mention whom they can contact, what is the telephone number of whom they can contact if they have any grievance, things like that. It is better for us also, because otherwise they will straight away pick up a phone and call the union minister, not even the chief minister or health minister here. They will call the union minister, even prime minister they might call. And they are supposed to answer their calls because they are a privileged category of people. They are supposed to answer them also. And things might go wrong for us also. And grievance redressal mechanism should be there, and an ombudsman at the state level to deal with the grievances of the PLHIV is mandatory. They have a grievance redressal committee at the state level also. They are supposed to meet, I think at least quarterly they are supposed to meet, and where from the district level, or they can present their grievances and find a solution from there. So all these are coming under the Act. I think with this I will finish my session. If anyone has any doubt, you can ask. Many of the things would have gone above your head, I know. But these key points, at least remember that we should not discriminate them at any place. We should not breach. There should not be any breach of confidentiality. And if, especially when you write your prescriptions, please remember, do not write patient on ART, HIV positive. So I have very often seen so many persons writing in boxes like HIV positive in a box, red box. They will mark it with red and write HIV positive on ART. And the doctor asked me, how can their patient understand what is on ART? What is wrong if he takes the prescription? I said, see doctor, this prescription is being taken outside the hospital. So they will take this, maybe not all drugs are given free of cost in our institution. So he will take it out and he will show to that lady came and told me, madam, I know the person sitting in the pharmacy outside the hospital. And suppose I show this to him, what will happen? So I coolly cut it and shaded it with some colors and saved the face of that doctor. So I said to the doctor that if you are able to give everything from yourself, then there is no problem. But you are sending so many outside. So they said that people can understand, madam, what is ART. Because you people always talk on so many medias and tell them about ART, antiretroviral. You yourself are talking to so many people. Everybody knows, so I just kept quiet. It is true. I've been keeping on talking about ART in the radio, in the TV, and maybe so many would have listened to me. And so I said, okay, I will do some correction regarding that. So what correction I can do? Once one lady called me up over the phone. See, I have been to a doctor and she has written, I'm an HIV patient on my prescription. So that is a private clinic, and she said, I'm going to file a case against the doctor. So at that time this act was not come into existence. I said, nothing will happen if you file a case. Why do you want to go after a case and things like that? It may be that they did not do it intentionally, and nobody will understand. Maybe you can rub it off and take it to the pharmacy, nothing will happen. So I said, okay, I will do as you said, but please warn these people. So I called up the doctor and said, now you have been saved, not always you will be saved. They can go to the court, I cannot anymore tell them, don't go to the court because the act has come into existence. This was something before the act. Now I cannot do anything, I can just keep quiet and keep my fingers crossed and hope that they will not do anything. So that everybody should remember. And somebody was asking me, what if I write on that? How will the other doctor know that? What purpose does it serve? Will it do any good to this patient if you write it? When they are asking me what happens if they come next time, how will I know that he is positive? I said, why should you know? You are not providing antiretroviral treatment from your clinic or from your OPD. You are just giving treatment for some other illness. You consider them as as a normal person. If it is needed that this patient requires a more advanced treatment, something related to the HIV infection, surely I will call you and inform you. Please, I will write a note for you. Please screen this patient for this and this in their green book, not on the prescription paper or not on the OPD letter. So please be careful regarding that, because we do not know whether they will hold this and say something that we have done something in their confidentiality has been broken. So with that, I think I will stop my talk. I have taken a lot of Anto's time, and thank you so much for giving me this opportunity to meet you once again. Thank you. Have a good day.
Acts are usually very difficult to present. They are sleep-inducing, but actually her presentation was very nice, crisp, lively, and interesting. Any questions?
Yes, sir.
So they are not supposed to write in this discuss summary also.
We should not mention he is on ART, he is a PLHIV, he is an HIV patient.
Even the investigation part, the HIV positivity.
No, we are not supposed to write anywhere. But sometimes, sometimes people used to ask like that. It's our discharge summary. But the fact regarding discharge summary is it is taken outside the hospital, right? So the patient might take somewhere and somebody might say, let me see the discharge card. You have been in the hospital, no? And suppose he goes through that.
In reference letter to another hospital.
Another hospital we can mention, but not in the discharge summary. Because discharge summary, what happens? Maybe his friend or his relative is a doctor, but he doesn't want to reveal. There are so many of my patients who are high profile patients. They do not like even, maybe they would like me calling them. They do not like even my staff calling them. Once the outreach worker called him and he is calling me back and telling me, what is this madam, that person is calling me, I don't want anybody else to call me. So there are few patients like that, maybe they do not want to, and there are some people who are in-laws or whose relatives are doctors. So they are telling me like this, they will definitely say, no, you have been in the hospital, show me the discharge summary, let me see what happened to you. How can he show that? So he has to, suppose he shows that if you write there, he is an HIV positive patient, his status is revealed. And we do not know whether that patient will keep it confidentially. You might go and say. So any paper which goes out like that, we are not supposed. But if you want to refer to a person, refer a patient, we can mention that he has these problems related to this illness.
Excuse me, I'm in the gynae department. Suppose a lady comes, she's on ART. She comes to the hospital for abdominal pain or something, she discharged. So naturally I give her a discharge paper. And she may come back to me or she may go to some other institution with that paper. How do I not write that?
You are not supposed to reveal the status, madam. You can write in your hospital records.
No, and suppose she comes with an abdominal pain, she wants to go back to some other hospital. She's identified as an HIV positive and she's admitted here. So now when she started on the drug and she goes back, she probably go to another local hospital for delivery. So how is it possible for me not to write that information?
For delivery, then what you can do is, ma'am, whenever a patient comes to you, then you can tell them that you have to reveal your status wherever you go. The person can reveal. Suppose she is going to get delivered to some other institution. She has to tell the doctor that she is on ART and she is a positive patient. Not us, but she has.
Suppose she doesn't. Suppose that is the responsibility of the answer.
That is the responsibility of the patient.
So that means
She has to.
Institution also has to test.
only possible.
And all the institutions will definitely test any.
No, they don't, because once the investigation has been done once, and then they throw the paper off. Many of they say they've already done it. So I think it's not really practical if a patient comes for admission for 2 weeks and then I identify this condition, I start her on the drug and then she says she wants to go home. And I don't mention that in the discharge card at all. Do you think?
But they will not put her on antiretroviral treatment. She is already on ART. So she can go back to her ART and take the treatment. No private facility will give the ART free of cost, ma'am. But we have to, no madam, what they are saying that we have to counsel the patient and tell them, make them prepared to reveal their status. That is all the answer they are giving us.
Have we used any other radio positive or something like that, not the common HIV like that?
Maybe previously we used to we used to tell them that if you want to just between us, if you want to pass on the message, we can write as PLW. PLHA, not PLHIV, PLHA, PLWHA we can write.
That
PLWHA
is
we
always
have,
right. That is right. But then I don't know how practical it is not to mention, because we have patients who go to several hospitals during the course of their pregnancy.
but they have to reveal the status now. That is the only thing that they are telling us. The person has to reveal.
Most of the patients when they come to us, even with STI, even if they are HIV positive, they will never tell us.
They will never tell us.
They will never tell us. That is the main problem.
They never tell us they HPV positive. They never tell us they are HIV positive. And it is with our instinct. It's not possible for us to use universal precautions, all these things. We've only got certain.
We are supposed to use universal precaution,
We don't
ma'am.
have that much.
That is the only answer that they are giving. Because any patient who comes in front of you are supposed to be having any infection. We are being told that we have to use universal precaution for every case.
Nobody reveals their status.
We are getting a blanket consent for the investigation. Is that that suffice for this
Consent.
HIV testing?
No, sir. I'll tell you why. We had a patient who came to the labor room in the middle of the night, and like she had. So they called us, telling us that a woman has come to the labor room. She has delivered, and we did the blood test. It is positive. So in that case, suppose a woman is not on ART, she has delivered, and we do not know whether she is virally suppressed. We are supposed to test viral load for all pregnant women after 32 weeks of pregnancy. So this lady, they said that she has not been registered anywhere. She is a migrant. She has come into the labor room and delivered. That was the call I got. So I said, anyway, I will come with my ICTC counselor. In that case, we have to do a dual therapy has to be given, not just nevirapine. So we went to the hospital. We saw her. She said, I have not been tested before. So I asked them, is she just coming, walking to the labor, or she has been seen by a gynecologist some time back. So she has already attended her antenatal training 3 or 4 times in our hospital, 3 or 4 times. But unfortunately, only her HIV test has not been done.
That's because they throw the paper away.
See, madam, only that was not done. All the remaining tests have been done. HB has been, the screening has been done, ultrasound has been done twice. Everything has been done. Not that she has not come to the hospital, but HIV tested. Why? Because that is the answer to your question, sir. Why? Because the house surgeon, maybe the house surgeon didn't know about that. They have just written all the investigations together. All the baseline investigation, all the routine investigation, whatever you do for a antenatal, they have done. Along with that, they have written HIV testing. And they have taken this paper to the main lab. But that HIV test will not be done there. They have to go to the ICTC center. But unfortunately, nobody told them that go to the ICTC and get it done. So that requires a separate consent form, separate counseling. Here in the main lab, they will not do any counseling for. Will anybody do any counseling for HBsAg and SBsAg? I have not seen. So, but unfortunately, that was a true incident. And some time back, unfortunately, somewhere it was lost. And she was not sent to the ICTC. If she was sent to the ICTC, maybe from her first trimester itself, she would have been registered in our ART center and got the treatment. Fortunately for the patient, for the husband was negative. And fortunately for the child was also negative. We immediately started dual therapy, and she herself told us, I will not breastfeed my child. So I really doubt whether she already knew she was positive. I do not know. It was a second marriage, and maybe her first husband had already died. Maybe he would have been positive, and she's a migrant. We do not know. We cannot task them to more than, we cannot just threaten them to reveal the status. No? So I think we need a separate consent form.
Problem comes. I am from cardiac surgery. My colleagues from cardiology, they used to reuse every catheters. I mean, cardiac surgery also, in your hospital also, cardiac surgery. All these reusing can have a problem. That's why we are always
reuse
testing.
But for cardiology testing, I think they do HIV testing.
If the patient doesn't give consent, then he has to.
No, but there you can do a testing. You can do a testing because it is for a procedure. It is for the benefit of the patient. So we will not be held to court. There you can do routine act because അത് ആ പേഷ്യൻറ്റിന് അത്യാവശ്യമാണല്ലോ. സപ്പോസ് ഈസ് HIV പോസിറ്റീവ് എന്നാണെങ്കിൽ ഈസ് ഗോയിങ് ഫോർ എ കാർഡിയക് സർജറി ആണെങ്കിൽ or any procedure ആണെങ്കിൽ അതും അതിനെ ബേസ് ചെയ്തിട്ട് വേണ്ടേ. Nobody will say anything. That they're in our hospital, they do for everything, everyone. But they send to the ICTC all the patients. അങ്ങനെയാണ് ടെസ്റ്റ് ചെയ്യുക. Here also maybe you can, if you are getting it tested through the ICTC, no problem. Counseling കഴിഞ്ഞിട്ട് we can say that pre-test counseling was done. After counseling we did got it tested. അപ്പോൾ പ്രശ്നമില്ല സർ.
One was the continuation of the discharge happened. If we don't reveal the status, when you go to the next hospital and meet another doctor, there is every chance that the patient is taking some drugs. There could be drug interactions, there could be other diseases which we may never think of.
Yeah.
Because we were not informed about it. We are expecting the patient to tell us, which is everything that is verbal. The patient could later come with and madam പറഞ്ഞ കണക്ക് the patient most probably നമ്മുടെ ലാബിൽ ഞാൻ പോയിട്ടുള്ളതാണ്. They usually don't do HIV, they tell go downstairs and do it test. So maybe പറഞ്ഞിട്ട് patient ആ വഴിക്ക് മുങ്ങിക്കുകയാണെങ്കിൽ and then the patient.
അല്ല മാഡം, അപ്പോൾ നമ്മളിപ്പോൾ ഒരു ഹോസ്പിറ്റലിലേക്ക് റെഫർ ചെയ്യുകയാണെങ്കിൽ ഡെഫിനറ്റ്ലി വി ക്യാൻ സേ. റെഫർ ചെയ്യുമ്പോൾ നമുക്ക് ആ റെഫറൽ ലെറ്ററിൽ നമുക്ക് എഴുതാം.
നമ്മൾ ഡിസ്ചാർജ് ചെയ്ത് വിട്ടു. ഈ പേഷ്യന്റ് വേറെ അസുഖത്തിന് അടുത്ത ഹോസ്പിറ്റലിൽ പോവാണ്. The patient is taking drugs which may have drug interaction. The patient can have adverse reactions which may be presenting as some other symptoms. HIV, as we know, is something which can present like anything. So the other.
പക്ഷേ മാഡം അവിടെയും നമ്മളോട് പറയണത് the patient should be counseled. അല്ല മാഡം, നമ്മൾ പറയുന്നത് patient should be counseled to reveal his status wherever he goes. ഇപ്പൊ കഴിഞ്ഞ ദിവസം ഒരു പേഷ്യന്റ് വന്നു, ലൈക്ക് that person has, നമ്മൾ എല്ലാവരോടും ആദ്യം മുതലേ പറയും, വേറെ ഏതെങ്കിലും ആശുപത്രി പറയുമ്പോൾ നിങ്ങൾ പറയണം why they are not revealing, because of the പേടിയാണ്.
Ma'am, I am saying is I understand the legality of it is now, but I think as a society, as doctors, we need to raise this point and maybe get some changes in the rules also. It's the first thing. Second thing is, ma'am, another slide in under the this committee na edhu cholliyana exemption for medical research and medical use na for adannu explain cheya because I don't understand what it means.
We will do it
So
very
no
fast.
point I just
Yeah,
slide
very late.
Earlier slides. Exception അല്ലേ? ഇതല്ലേ? എക്സെപ്ഷൻസ് അതല്ല. അതെ, അത് തെറാപ്പി എന്ന് വെച്ചിട്ടുണ്ടെങ്കിൽ ട്രീറ്റ്മെന്റിന്. ഇപ്പൊ ലൈക്ക് ഇപ്പൊ അയാൾക്ക് എല്ലാ സിംറ്റംസ് ഉണ്ട്, അയാൾ ഈസ് കൊമാറ്റോസ്, അയാൾക്ക് എന്താ പറയുക, അല്ല അപ്പൊ മെഡിക്കൽ റിസർച്ചിന് വിതൗട്ട് റിവീലിംഗ് ഹിസ് ഡീറ്റെയിൽസ്. മെഡിക്കൽ റിസർച്ചിന് അവർ ഉദ്ദേശിക്കുന്നത് ഇപ്പോൾ ലൈക്ക് ഇരുന്നോളൂ മാഡം, വി ഡിഡ് HPV സ്ക്രീനിങ് ഫോർ അബൌട്ട് through a sponsorship program. We did HPV screening. They said they will do for 200 patients. അതൊരു റിസർച്ച് ആയിരുന്നു. ഓക്കെ, they got it sanctioned from the external society and we said that we will not reveal any details of the person. You can do the study. They were doing all HPV testing ആയിരുന്നു അവർ ചെയ്തത് ഫസ്റ്റ്. അത് കഴിഞ്ഞിട്ട് അതിൽ HPV പോസിറ്റീവ് ആയവരെ കൊൾക്കോസ്കോപ്പി, തെർമൽ എബ്ലേഷൻ, അങ്ങനെ കുറേ സാധനങ്ങൾ അവർ ചെയ്തു. That's of course a useful procedure for our patients also. And patients ആകെ 146 ആളെ വന്നുള്ളൂ. ഇന്ന് 30 ആളോട് വരാൻ പറഞ്ഞാൽ 5 ആളെ വരുള്ളൂ, അങ്ങനത്തെ ആൾക്കാരാണ്. അപ്പം അങ്ങനെ നിരങ്ങി 2 മാസം കൊണ്ട് ഒരു 148 ആൾക്കാരെ നമുക്ക് കിട്ടി. പക്ഷെ we said we will not reveal a name or anything to you. അതിന് വില്ലിങ് ആണെങ്കിൽ you can do the medical research. അപ്പം അവിടെ പക്ഷെ ഓൾറെഡി നമ്മുടെ പേഷ്യൻ്റ് ആയിരുന്നു. അവരോട് പറഞ്ഞു നമ്മൾ, റിട്ടേൺ കൺസെന്റ് ഒന്നും മേടിച്ചില്ല. ബട്ട് വി ടോൾഡ് ദം ദിസ് ഇസ് ബെനിഫിഷ്യൽ ടു യു ഓൾസോ. ഇഫ് യു ഗെറ്റ് ടെസ്റ്റഡ് ഫോർ HPV ആൻഡ് ഇഫ് യു ആർ പോസിറ്റീവ്, ദ ഫർദർ പ്രൊസീജിയേഴ്സ് വിൽ ബി ഫ്രീ ഓഫ് കോസ്റ്റ്. അങ്ങനെ അവരെ കൗൺസിൽ ചെയ്തിട്ട് അവിടെ നമ്മൾ അത്ര കെയർഫുൾ ആയിട്ടാണ് കൊടുത്തത് പേഷ്യൻറ്റിന്. നമ്മുടെ കെയർ കോർഡിനേറ്റർ തന്നെ കൂടെ നിന്ന് പേഷ്യൻറ്റിൻ്റെ ഒപ്പം നിന്ന് ടെസ്റ്റിങ്ങിൻ്റെ സമയത്തും കോൾപ്പോസ്കോപ്പി ചെയ്യണ സമയത്തൊക്കെ പോയി. അപ്പോഴും നമ്മൾ ഇതുവരെയും അവർക്ക് റിവീൽ ചെയ്തിട്ടില്ല അവരുടെ ഒരു ഡീറ്റെയിൽസും. അങ്ങനെ നമുക്ക് അതാണ് മെഡിക്കൽ റിസർച്ച്. അല്ലാതെ സോ ആൻഡ് സോ ഇത്രയും ആള് ഇന്ന സ്ഥലത്ത് അങ്ങനെ തന്നെ നമുക്ക് കൊടുക്കാൻ പറ്റും.
inform them back. For example, I'm doing a testing in the whole of hospital. I find 5 people have HIV.
You can inform.
അപ്പോൾ എനിക്ക് ഇത് കോഡ് ബ്രേക്ക് ചെയ്ത്
അയക്കാം.
അങ്ങനെ കോഡ് ബ്രേക്ക് ചെയ്യണമെങ്കിൽ ഐ നീഡ് ടു നോ ഹൂ ഇസ് ഗെറ്റിംഗ് ടെസ്റ്റഡ്. കാരണം HIV പോസിറ്റിവിറ്റി എന്ന് പറഞ്ഞൊരു വലിയ ഇഷ്യൂ ആണ്. യു നീഡ് ടു ട്രീറ്റ് ദം. അതാണ് ചോദിച്ചത്. അനോണിമൈസേഷൻ ഒക്കെ അവിടെ എങ്ങനെയാണ് നടക്കുക? അതിനകത്ത് വല്ല ഗൈഡ് ലൈൻസും ഉണ്ടോ? But how we can go about anonymizing their data? When we should break the code എന്നുള്ളത്.
അല്ല, അത് വേണ്ട. അതാ പറഞ്ഞത്. ഇപ്പോൾ പേഷ്യൻ്റ് പോസിറ്റീവാണ് നമ്മൾ കണ്ടെത്തിയാൽ നമ്മൾ അവരെ അയക്കേണ്ടത് നമ്മുടെ ART സെൻറ്ററിലേക്കാണ്. ART സെൻറ്ററിൽ വീണ്ടും കൗൺസിലിംഗ് ചെയ്തിട്ട് അവരോട് ഒന്നും കൂടെ പറഞ്ഞു കൊടുക്കും. ദാറ്റ് ഈസ് ഹൗ തിങ്സ് ആർ ഗോയിങ്. നമ്മൾ വെറുതെ ഫിസിഷ്യൻ്റെ അടുത്ത് വിടണ്ട. സാറിന് ചെയ്യണേ. Okay.
I think there are some ambiguities in this act. I mean, man can continue like only when a problem arises, court will say what is right and what is wrong. There are a lot of ambiguities, all this research and all. Okay, thank you very much.
I would like to request Dr. Santosh sir to kindly hand over the certificate and memento to Dr. Parvati.
Next, I would like to invite Dr. Peter P. Varil, Associate Professor of Department of Pediatrics of GMCE Ernakulam, to chair the next session. Now let us invite Dr. Shiji K. Jacob, who will speak on the topic Child Living with HIV. Ma'am is the head of the Department of Pediatrics of Government.MEDICAL College, Ernakulam. Her areas of interest are developmental neurology, nutrition, asthma. She has around 15 publications, indexed journal articles. She has also co-authored chapters in textbook of pediatric resuscitation and emergency medicine.
So at the outset, let me thank the organizers for asking me to chair this session. Even though we speak a lot about HIV infection in adults,
do cases occasionally in our OP also. So over to our Professor HOD Pediatrics to enlighten us on this topic.
A very good afternoon to all of you. First of all, I thank the organizers, especially Dr. Sandhya Madam, Dr. Deepa, Dr. Preeti, Dr. Antu, and all the organizers for giving me this time. As we all know, today is World AIDS Day, HIV Day, and the slogan of which is take the rights path, that is to protect and to promote human rights in fight against HIV. Actually, when we think currently, around the globe, every 5 minutes, one child dies of AIDS-related illness. So that is the burden, the global burden of the disease. So it is our duty to educate ourselves, as Madam was telling, and the public against, regarding HIV. And also, it is, so it's our duty. Okay, so with that in mind, we'll just see a little about pediatric HIV. The learning objectives are to the clinical manifestation, immediate care at birth, infant feeding, immunization, ARV, co-triamcinolone prophylaxis, early infant diagnosis, follow-up diagnosis and management. And as we all know, I'm not going at all into, I'll just only, not making you bored, I'll just only touch the points. HIV, as we all know, belongs to the retrovirus group, and it is very fond of the T cells of the immune system. And one thing which is very dangerous about HIV is that it contains the reverse, transcriptase enzyme. And this enzyme is the one, the villain, which, it converts the genetic material of the HIV RNA into HIV DNA. And once it becomes the DNA, it enters into the nucleus, and thereby it incorporates into the human DNA. and thereby as the virus multiplicates, as the cell multiplicates, it gets into all the cells. And that is the importance of HIV, knowing the dreadful condition of HIV, that you cannot eradicate HIV, you can only prevent the replication, you can arrest the replication of the HIV. The symptoms, the clinical status. Now, WHO has staged the HIV into 4 stages, and that is based on the clinical status and the immunological impairment into stage 1. Stage 1 is, is symptomatic, and in children they are present with flu and, fever of prolonged duration, organomegaly like that, persistent lymphadenopathy. Stage 2 is characterized by unexplained persistent hepatosplenomegaly, papillary, pruritic eruptions, fungal infections of the nails, angular cheilitis, gingival erythema, extensive wart, as we see, multiple abscesses, extensive molluscum, recurrent oral ulcerations, unexplained persistent parotid enlargement, herpes zoster. Now, these are the multiple abscesses that we can see, the molluscum contagiosum, then the herpes simplex ulceration. Now, stage 3 is characterized by unexplainable moderate malnutrition or wasting, and unexplained persistent diarrhea which lasts for more than 2 weeks, persistent oral candidiasis, oral hairy leukoplakia, acute necrotizing gingivitis, lymph node or pulmonary tuberculosis, severe bacterial pneumonia, then that is lymphoid interstitial pneumonitis, and so on. Stage 4 is the one which is, even more worse, characterized by severe wasting and pneumocystis carinii pneumonia, recurrent severe bacterial infections, esophageal candidiasis, extrapulmonary or disseminated tuberculosis, Kaposi sarcoma, CME infections, CNS toxoplasmosis, and extrapulmonary cryptococcosis. HIV encephalopathy all belongs to stage 4 of the illness, chronic cryptosporidiasis, chronic isos, and so on. So these are based on the clinical status and based on the immunological impairment. Now, the respiratory disease, I'm not going into details at all, is most common in children is pneumocystis carinii pneumonia caused by pneumocystis jirovsky. And, it is a treatable condition. It's more common in infancy, can be treated by, by giving, prevented by giving cotrimoxazole or prophylaxis. Recurrent bacterial infections are common, can present with severe pneumonia. The symptoms and signs are same as that of pneumonia, but it takes more time to act and it's difficult to treat. Tuberculosis, coexisting TB and HIV is very difficult because it results in the progression of tuberculosis as well as HIV. And most common type of TB that is seen extrapulmonary and disseminated tuberculosis. Viral infections are very common because, CME, persistent CME, extensive CME infection is very common, fungal infection, and lymphoid interstitial pneumonitis. It is one of the very distinctive illness of childhood HIV, and it is characterized by nodule formation and it affects the septa of the lungs. This can also be prevented and treated if it is recognized early. Gastrointestinal diseases, infections by bacteria, protozoa, fungi, all types of infection. AIDS enteropathy, it is because of the, this HIV can cause partial destruction of the villi resulting enteropathy. It can cause chronic liver infections by all these hepatotropic viruses, can also cause pancreatitis. Neurological disease, that is progressive neurological diseases in children is one of the classic findings of HIV in children, and it can be diagnosed by impairment of cognition and also losing or regression of milestone. Suppose a child, 1 year or 2 year old child who had already attained milestone comes with, and who is an HIV positive child comes with regression of milestone, one can think about HIV encephalopathy. Cardiovascular diseases are also common, can cause a deterioration of LV function. Renal function nephrotic syndrome is one of the common manifestation of HIV in children. Now, coming to management, this is the NACO guideline or the AIDS Control Organization Guideline 2021 for prevention and for protection of HIV. Mother to now, see, when we think about CLHIV or pediatric HIV, 90% of all the HIV in children occurs during transmission, during pregnancy, that is mother to child transmission. And so the components of care includes, one is immediate care at birth. Immediate care at birth, then regarding feeding, we'll come to it. That is immediate care at birth. You know, infants should be handled with gloves. These are all the important points, the common points. The cord should be clamped and cover the cord, and infant feeding in the first hour. Now, infant feeding, we'll think that how can we, if HIV positive mother, feed the baby? Yes, they should feed the baby. Exclusive breastfeeding up to 6 months and thereafter complementary feeding, because when a mother is already on anti-ART, that itself gives protection all the more, and also breast milk contains factors which are very protective against this disease. So one should, but if the mother chooses not to feed, it's okay. But what we should advise is exclusive breastfeeding to the mother, to the baby. Complementary feeding should be started with nutrient-rich, energy-dense and iron-rich food. Now, infant ARV prophylaxis, in addition to the maternal ART, all the HIV exposed babies should be given prophylactic ARV drugs. That is very important. And as per the current guidelines, plasma viral load, because once the HIV enters the body, two things it does is that it will kill, it will damage or kill the lymphocyte, and the virus will multiply. So viral load is an indication of the disease severity. So plasma viral load should be done in all the pregnant women between 32 weeks and 36 weeks of pregnancy. And infants born, and those mothers which one who has got a less viral load, that is a low risk case. This is the risk stratification. Low risk infants are the one where the infants are born to mothers with a suppressed viral load, or when the viral load is less than 1000, that is a low risk, and for which only nevirapine is used as prophylactic drug, whereas high risk infants, that is infants born to HIV positive mothers who are not on ART, or maternal load is more, or maternal plasma viral load is not suppressed. In those cases, a combination dual prophylaxis have to be given, both nevirapine as well as sidovudine. Immunization in CLHIV, again like breastfeeding, all the vaccines should be given. All recommended vaccines should be administered to HIV exposed infants. All killed vaccines should be given, and also live attenuated vaccines are contraindicated in severely immunocompromised infants and children with HIV infection, only in severely. Okay, the rest all vaccines can be given, and live attenuated should not be given when the CD4 count is less than 15% or the count. And then co-trimoxazole prophylaxis. The idea behind giving co-trimoxazole prophylaxis is to prevent, is to reduce both the mortality as well as the morbidity in children with HIV infection, and also it protects from pneumocystis carinii pneumonia, and also malaria, diarrhea, toxoplasmosis, etc. So all HIV exposed infants should get co-trimoxazole prophylaxis from the age of 6 weeks. So at birth they have to be, irrespective of the status. We are not doing the viral load in the child, in the baby. Only we are taking care during pregnancy, during delivery. But at birth, all the babies should get ARV prophylaxis. But at 6 weeks, from 6 weeks onwards, they should get co-trimoxazole prophylaxis. And this is the when to start co-trimoxazole prophylaxis, that is at 6 weeks. All HIV exposed infants should get co-trimoxazole from the age of 6 weeks, and it should be continued. And then the HIV infected infants should, regardless of the WHO stage or CD4 counts, at 5 years the testing can be done, and then thereafter it can be stopped. But HIV infected infants more than 5 years of age, WHO stages 3 and 4, regardless of CD4 count, only when there is clinical and immunological impairment, we can stop the cotrimoxazole prophylaxis. So, and so that is the importance of cotrimoxazole prophylaxis in HIV infected children. Now, regarding the growth monitoring is very important. That will help us to know whether the child's growth curve, whether there is flattening of the growth curve. If there is flattening of the growth curve, that again indicates that the child is not growing properly or the child is having an advanced disease. Now, early infant diagnosis. Why we are not doing an antibody testing is because the mothers anyway will have maternal antibodies, and this maternal antibodies will be passively transferred or transported to the baby. So, and this will last, in some infants it will last for 9 to 12 months, sometimes it may go up to 18 months. So there is no point in doing an HIV antibody at birth. That is why we are not doing that test. So, NACO guidelines, they have proposed certain things. Now, this is the algorithm. That is, I'll make it very simple. That is, a baby who is born less than 6 weeks, less than 6 weeks to 6 months. If the baby comes at less than 6 weeks to 6 months, if the baby comes at less than 6 weeks to 6 months, what we have to do is we have to collect blood, one blood sample, that is dried blood sample for HIV PCR test. Okay, and if that is positive, if that is positive, if HIV is detected in the first sample, you got to do another blood sample. If the second sample is also positive, then the baby is directed to the ART center for taking ART. Suppose if the first sample is positive, but if the second sample it is not detected, then the baby is closely monitored for the growth and development, or the baby can be monitored for any development of symptoms. And also, if the second sample, again, if second sample is not detected, then again the baby can be observed. Now, if the baby comes after 6 months, we have to do an antibody testing. Only if the antibody is reactive, or if the antibody is negative, then we need not do the HIV PCR test. If the antibody is positive, then we got to do the HIV positive PCR test, and the baby has to be started on antiretroviral therapy. And for definitive diagnosis, next when we have to repeat it is Ganesh, when for definitive test, next testing is only at 18 months. Only at 18 months of age, or 3 months after the cessation of breastfeeding, whichever is earlier. Now, this is the algorithm for when the child comes after 18 months. It is the same strategy that we use as if for adults. When all the 3 tests are positive in an asymptomatic baby, it is the child should be put on lifelong ART. If it is positive, only 2 tests are positive in a symptomatic baby, then also it is considered positive. And 2 tests positive plus 1 test is negative, again it is considered as indeterminate, and it should be monitored. Okay. So, now how do we follow? So that is regarding ART. And how do we follow up the child who is exposed or HIV exposed children? At birth, we already said we are not doing viral culture, we are only giving the ARV prophylaxis. At 6 weeks, we have to start on, At 6 weeks, At 6 weeks, we have to immunize the child as for all other immunization, as we do for all normal children. And we have to start on co-triamoxole prophylaxis. Then we have to counsel for the feeding. Now, growth monitoring is done at all the visits using growth chart. Immunization, vitamin supplementation is done for all these things, and all the vaccines can be given except when it is severe immunosuppression. Now, management of newly diagnosed is now this is another thing that we should know, that is when do we say that there is immunosuppression? Only, if the CD4 count is, in severe cases it is less than 25% or less than 1500 cells in children less than 1 year, or 5 years more than 500 cells or less than 15%, we say that it is severe. Okay. Now this is very important, that is management of opportunistic infection. Now, if the child is suffering from, if there is an undiagnosed fever while on an HIV exposed child, then you have to diagnose and treat the fever first. For same thing for tuberculosis or pneumocystis pneumonia or invasive fungal illness, bacterial pneumonia, malaria, everywhere we have to treat the primary condition first and then start ART. Now, skin condition, start ART. Cytomegalovirus virus infection, again we have to treat the CME first and then start ART after the induction phase. Toxoplasmosis, severe malnutrition also, the malnutrition should be corrected with energy dense food. Now, when to start ART for infants and children? ART should be initiated for all the children, irrespective of the CD4 counting and WHO clinical staging. Even if the child is stage 1 or if the CD4 count is normal, also HIV exposed children should be started on ART. So confirm the HIV infection and treat and stabilize with the opportunistic infection has to be stabilized and initiate the first line ART drugs. Now, ART regimens, when coming to the ART regimen, just I'm not going into pharmacology, but the most important thing, as I just said before, is one is, the reverse transcriptase enzyme. It converts the HIV RNA into DNA. So that is where our NRT or nucleoside reverse transcriptor inhibitor will hit. So that is why NRTI forms the backbone. It is called as the backbone drug. That is the most important. NNRTI also is it directly acts on the reverse transcriptase enzyme. There is protease inhibitor, then there is one more drug that is called integrase inhibitor. All the other drugs are called anchor drugs. The backbone drug is the NRTA, all other drugs are the anchor drugs. Now, integrase inhibitor is a very good drug because the drug interaction is very less, and there have been various studies, I forgot the name of the study, which showed its protective efficacy against HIV, and that is the one which prevents against the HIV DNA from incorporating into the cellular DNA. So that is where integrase inhibitor acts. So it has been proven to. So our drug is. So once the HIV infection is confirmed, age less than 6 years, and body weight less than 20 kg, the drug is 3 drugs, 2 NRTA plus 1 NNRTA we can give, that is APALL. Second one is 6 to 10 years and body weight 20 to 30 kg, we can give abacavir, lamivudine and dolutegravir. This dolutegravir is the integrase inhibitor, ALD, and age more than 10 years and body weight more than 30 kg, of course like adult, we can give TLD, tenofovir, lamivudine plus dolutegravir. So just know only one word regarding the mechanism of action will be very good for us to practice medicine. Now, this is again when there is co-infection with tuberculosis, initiate anti-TB first, and ART should be started as soon as possible within 2 weeks of initiating TB regardless of the CD4 count. But among children living with HIV and TB meningitis, ART should be delayed at least 4 weeks. after treatment for TB meningitis. And so that is very important. And regarding the drugs also, we're not going into detail because treatment of HIV will take hours, diagnosis will take hours, symptomology to discuss also will take hours. I'm just touching the important points. Now, advanced disease management in children less than 5 years, newly diagnosed. Now, advanced HIV disease includes newly diagnosed CLHIV less than 5 years, severe immunosuppression following treatment failure. And so these children, the main intervention as recommended by HIV to reduce the morbidity and mortality among CLHIV is stop AIDS. That is screening, treating, optimizing and preventing AIDS. Stop AIDS. This is stop AIDS. That is, we should screen for a child who is an HIV child. We should screen for tuberculosis. Screening for tuberculosis for 4S screening. 4S screening is nothing but 4 symptoms. That is fever, persistent cough, and there is night sweats, temperature, etc. Weight loss. These are the 4S screening. And other testing, screening for cryptococcal infection. Again, we can rule for cryptococcal antigen and all these things we can do. Then we can screen for malnutrition. Another one, so these are screening, 3 important things. One is tuberculosis, second one is cryptococcal infection, third is malnutrition. And treating TB, severe pneumonia now, pneumocystis carinii pneumonia. When a child comes with severe pneumonia, one should always think about pneumocystis carinii pneumonia, and it's a treatable condition, but unless it is thought, it cannot be treated. We can give co-trimoxazole every 6 hourly for 21 days with or without steroids. And cryptococcal meningitis, etc. can be treated, optimized by giving rapid and ART at earliest before discharge. And ART has to be given and counseling has to be done. Now, and also regarding co-trimoxazole prophylaxis, prevention of cryptococcal meningitis among adolescents by giving fluconazole, all immunization as per the immunization schedule, and vitamin A also has to be given. Now, how do we monitor the child who is on ART? We are coming to the end. How do we monitor a child who is on ART? One is by clinical monitoring, second is laboratory monitoring, immunological monitoring, and viral load monitoring. Now, clinical monitoring, we got to check the growth and nutrition of the child at all visits, because a flattening of the growth curve indicates that the child is not taking drugs properly or the child's immune status is going down. So, and development progress milestone has to be noted in all visits, because as we said, HIV encephalopathy is a dreaded complication. Four symptom screening for tuberculosis has to be done. Then, so all these things has to be checked. Then laboratory parameters, we got to check for the hemoglobin and the complete blood count, urea, LFT, urine analysis, creatinine. All these tests can be done in every visit. So this is how we then virological monitoring, serial viral monitoring is done in all children initiated on ART. This is done at 6 months and 12 months after starting ART, and annually thereafter. So this is very important. We need not enthusiastically do the viral load testing after 1 month or 2 months. It is done 6 months, after 6 months and 12 months, and after starting ART, and annually thereafter. Now, so if the viral load is more than 1,000 copies, and if there are opportunistic infection, adherence counseling must be done. Now, treatment failure is very, very common. Now, how do we know whether the child has responded well, or what are the indications of treatment failure? Now, these are the indications of treatment failure. There can be 3 important methods. That is, one is a virological failure, second one is an immunological failure, third is a clinical failure. Now, virological failure is even after starting, after 6 months of ART and 3 sessions of step-up adherence, even even after that, if the viral load is more than 1,000 copies, that indicates a treatment failure or virological failure. And immunological failure, even after children between 1 to 3 years, if the CD4 percentage falls below 15%, according to the age, if the CD4 count is going low and low, that means there is an immunological failure. And clinical failure, the stage, if they're going into stage 3 or 4, that means the child has got a clinical failure. So in such conditions, when there is a clinical, an ART failure, treatment failure, you got to go for a second line ART drugs. These are the drugs that are shown. That is, one can go with all these drugs. Now, the next is sometimes even on second line ART, the child again can get, may develop resistance. That is because of the poor adherence and because of the improper dosages or late starting of second line drugs. One can go, there can be treatment failure. So in such cases, third line ART drugs are used. And but again, so the take-home messages are, I want to leave with you 5 P's. Yeah, 5 P's. One is prevention. That is prevention, mother to child prevention is very important. As we heard earlier, so, there is universal precaution should be done. And I was thinking about our gynec madams and how much it will be so difficult to think that all patients are HIV positive. What we heard just now is we can't even ask them. So that means we should think that all are HIV positive and should have that that prevention, because 90% of children with HIV are due to mother to child transfer. Prophylaxis we have to give, that is the cotrimoxazole prophylaxis and ARV prophylaxis. That means any child who is born to an HIV exposed mother or any child who is HIV exposed, irrespective of the viral load or anything, we are not checking viral load at birth. We are only giving ARV prophylaxis. And ARV prophylaxis, low risk means one drug, and high risk means dual prophylaxis has to be given. Cotrimoxazole prophylaxis is started at 6 weeks. And then protection. Protection has to be given with immunization. Immunization given protection, because protection, all vaccines should be given, but live vaccines should not be given in severely immunocompromised children. Prompt initiation of therapy, that is drugs, as early, when should we start? As soon as possible. In ARV prophylaxis also, it should be done immediately after delivery, but even if it is up to 72 hours, it's okay, or even, late is good, much better, can be late but not delayed at all. So one has to start as soon as possible with the drugs, which we have already said. And public participation is very important. That is, I was thinking, these children, we have to be the voice of the voiceless, because these children, we have to be good advocates of the vulnerable and the marginalized. There are so many HIV infected people who are marginalized, belonging to marginalized people, like they are drug abusers, so many things are which I don't want to say. Should not look down on them. And so also the vulnerable group like children, it is our duty to take care of them and to be a voice for the voiceless. So think about the prevention, prophylaxis, protection, and the prompt initiation of therapy and public participation. So with all this, thank you so much for your patient listening.
Thank you, Shiji Madam, for the excellent presentation. The topic is open for discussion. I think the 5 P's are very, very important as far as pediatric HIV infection is concerned. Any doubts? We have 5 minutes to 1. Pediatricians are there.
We have another meeting for them on Monday. That's why they are keeping quiet.
So if there are no doubts, we will wind up the session. Thank you.
Thank you, Dr. Peter. Thank you, the organizers. Thank you.
I would like to request Dr. Peter, sir, to kindly hand over the memento and certificate to Dr. Shiji Madam.